I am now pleased to introduce our first speaker. Dr. George Mensah is Division Director at the National Heart, Lung, and Blood Institute Center for Translation Research and Implementation Science at the National Institutes of Health. Dr. Mensah leads an integrative effort to advance the translation of scientific discoveries in heart, lung, and blood diseases research to clinical and public health practice nationally and globally. In addition to his years of service in public health at the Department of Veterans Affairs and the Centers for Disease Control and Prevention, Dr. Mensah is an expert on health disparities in public health. Today, he's going to help us understand the complexity of vaccine hesitancy in high-risk populations and some disparities. Dr. Mensah?
Sherry, thank you very much for the wonderful introduction. And I should say that it's a real pleasure for me to give this presentation on behalf of our NIH-wide Community Engagement Alliance Against COVID-19 Disparities. This is an initiative that we call the SEAL Initiative. And first, let me also express our gratitude for the NIHCM leadership and staff for thinking about including us in this important webinar. What I'll try to do in the next 10 to 15 minutes is first set the stage so that we're all using the same terminology. I'd like to define just a few things and then delve a little bit more deeply into vaccine hesitancy. The NIH Strategic Plan on Minority Health and Health Disparities was just published, and I referenced the categories of race and the definitions of minority populations. The four categories shown here what we now recognize as the racial and ethnic minority populations, categorized by race. It's important to highlight that not all of these four have been disproportionately impacted. And as Sherry mentioned at the beginning, American Indian or Alaska Native, Black or African American, Native Hawaiian or other Pacific Islanders have been the most impacted within these four. We also recognize categories by ethnicity, and of course there are individuals who disclose two or more race categories. The panel on the left shows you what we're talking about, that huge and disproportionate impact on some racial and ethnic minority groups. Comparing the rate per 100,000 population, you see the substantially higher rate in American Indian or Alaska Natives, in Black and Hispanic compared to white and Asian or Pacific Islander groups. And in the panel on the right, we highlight that this is a result of an interplay of several things, including clinical characteristics, a very, very important component of social determinants of health, and very often exposure to the type of work that individuals do, as well as access to care, as was mentioned. This next slide actually puts these in numerical context. If you look at the number of cases, you see in American Indian or Alaska Natives where you have nearly a twofold increase, and in Black and Hispanic or Latino persons, 1.5 to twofold increase. Hospitalizations are substantially higher. In American Indians, almost a fourfold difference compared to white. Again, Black or African American and Hispanic or Latino persons, also 3.5 to fourfold. And of course, we know about the mortality differences, almost a 2.5 to threefold greater rate of death in American Indians, is similarly high, 2.8 to threefold greater in Blacks and Hispanics. Now, vaccine hesitancy is very common, but it's also a continuum. And in this image, we define it as the area in the red box. That's the area between individuals who are ready and willing to accept a vaccine right away. They are shown in the green. And at the very other extreme is individuals in the red who are very clear they don't want to have anything to do with the vaccine. But we have a huge opportunity represented in the box. These are individuals who are not sure. Maybe they want to wait to see other people get the vaccine, but then they will take it, all the way to the other end where they don't want it at all now, but maybe they'll change their mind. We see it as a unique opportunity to provide trustworthy, consistent, fact and evidence-based information so that we can help them make the right choices in accepting the vaccine. So it's a spectrum between those who completely accept and those who completely refuse. But we shouldn't really exclude anyone. We should make sure we provide the information to as many people in the red box as possible so that we can increase the number of people who accept. There are many reasons for vaccine hesitancy. I've listed here 4 that are very important. There may be questions or concerns about benefits and safety or side effects. And for others, it may be concerns about the speed with which the vaccine has been developed. They want to know if any corners have been cut. There are others who are hesitant because they distrust the system, and including even the government and the companies involved. And finally, there is just rampant misinformation from conspiracy theories about sometimes just factual inaccuracies. We all have a public health responsibility to be patient and answer all the questions and provide information so that the concerns can be allayed. Why is this important? As you see here, the national trend suggests that if you look at the proportion or the percentage of U.S. adults who say they are likely to get the vaccine from the period of April earlier this year through until most recently, that trend of the number of respondents willing to accept it has been going down. And that should be a concern to all of us. I'll show you several slides that actually demonstrate that this national trend may actually mask important differences at the racial and ethnic minority level. In this JAMA paper, if you take a look at the bottom of the table where we show race and ethnicity, I've highlighted in yellow showing that back in April, only about half of African Americans were willing or likely to get the vaccine, but by the November-December period, that had gone down as low as 37%. The proportions for the other racial and ethnic categories are shown. This next slide makes it even more serious, and why we all need to do our best to try to change this. The vaccine intent is lowest if you look in the bottom green. Only 12% say that they would definitely intend to get the vaccine. It's also lowest in young people. When you look in the hesitancy by age group, the lowest 22% in those age 18 to 34. I've shown you in this survey from the Kaiser Family Foundation, showing in green is those who are ready to roll up their sleeves and get a vaccine as soon as possible. But at the very end of the chart, you see the 15% for total U.S. level of the survey and 15 to 18% for Black, Hispanic, and white. But the most important thing I want to demonstrate here is if you look in African Americans, almost 2/3 were vaccine hesitant. About half of Hispanics were vaccine hesitant. This is the challenge that we face that we want to make sure we can address. There is some good news, but all that good news suggests is every effort we make is likely to be very successful, but we have a lot of work to do. In that period that you see here from September to December, in African Americans, their acceptance or the willingness to accept has gone up from 50 to 62%. It's gone up in Hispanics. It's gone up in everyone, and that's a reflection of the work that all of you have been doing. We just need to do more and more so we can get to the 80–90% aspirational goal. Here are some important concepts that we have to take into account so that we can successfully address vaccine hesitancy. One size definitely doesn't fit all communities. We must contextualize our efforts to specific communities, and all of the work must begin by listening to the community's needs, their concerns, and that listening exercise will help us tailor and contextualize efforts. A very important strategy to use is to address the 3 C's. This is the 3C model that looks at confidence, it looks at complacency, and looks at convenience. And I've highlighted trust because it's foundational to confidence. We must elicit what goes into the distrust and do everything possible to address that. Complacency is also some people believing that maybe, COVID-19 is not that serious. It might even disappear on its own. We all know it is not. We need to take steps to listen first and put in place mechanisms that address their complacency, and certainly making sure we can direct people to where the vaccine is available. We have to make sure we understand we can't do this alone. We have to work in partnership. Certainly, counting on trusted voices and trusted messengers is key, and they vary in different communities. In some communities, it may be the doctors and nurses. In other communities, it may be the pharmacists. It may be the clergy and other faith-based organizational leadership. The voluntary organizations that have been working in our communities for a long time have a strong track record, and they may be the trusted voices. We have to realize that we should not try to do this work alone, and we must work in partnership with these trusted voices. In my 1 or 2 final slides, I've summarized here some of the effective communication strategies and tools that we can use, and other mechanisms and strategies for building trust. We really have to take all of these into account and make sure that we are likely to be successful. Here is a website for the, before I get to the website, showing you where we have teams in the U.S. Working on addressing vaccine hesitancy, working on addressing inclusive and diverse participation in all our efforts, and we're very eager to share with you everything we have learned so far. The teams in our state are also very, very eager to help. Here is the website for our Community Engagement Alliance, and it's covid19community.nih.gov. I'll finish with this takeaway message that vaccine hesitancy is important, is dynamic, therefore it can change, but that change requires community engagement, it requires effective outreach, it requires building trust and helping understand the vaccine process, and most importantly, always sharing truthful information. I will stop here and turn it back over to Sherry and say thank you very much for including us in this important work.
Thank you so much, Dr. Mensah, for that comprehensive analysis and the extremely valuable solutions to the problem, and those slides which will be on our website after the event.